Hi all, I'm Margaret. So I will be presenting on addiction today. But before I kind of jump into that, I just want to thank everybody who's gone before me because all the presentations have been absolutely fabulous, and I've really enjoyed working with everybody and doing the course responses. So without further ado, I will figure out how to share my screen and I will start my presentation. Really quickly. All right. Share. All right. So, as I stated, I'm presenting on addiction. And providing history for the definition of addiction and the treatment for addiction proves difficult because throughout history, humanity has struggled with substance abuse addiction and addictive behaviors. One of the really prominent substances abused across the world is alcohol. But if you look historically, there has been other substance abuse. Opium is one of the really big ones. You can think of the opium wars between Asia and Great Britain. So for the purpose of this presentation, I'm going off of the course text. And the primary focus was substance use disorders when talking about addiction. I do touch a little bit on behavioral addictions, such as gambling, for example, which was reclassified in the DSM-5 as an addiction, where previously it was a behavioral issue, or is classified as a behavioral issue. And I do include the diagnostic criteria in this slideshow, and I kind of touch on the fact that there's a lot of overlap in what you would see as far as diagnostic criteria for gambling addiction when you compare it to substance abuse addiction. But the scientific classification of substance use disorders began in the early 19th century. So that's really where we start seeing assessments and substance use disorders as a diagnosis for patients. In addition to talking about gambling disorders and substance use disorders, we're also going to talk about substance-induced disorders because that's covered in the Zalewski test and the DSM-5. So that would be substance intoxication and substance withdrawal. So those disorders come as a direct result of your use of substance use. I've already done this presentation, so I'm gonna just go straight to YouTube because for some reason it will not play the videos in the Google presentation slides. So you should be able to see this. If not, I will share the link.
If you are thinking of seeking treatment for yourself or a loved one, you are not alone. The number of people suffering from addiction in America is astounding. Let's take a look at some numbers, starting with adolescents. It is estimated that in 2017, approximately 4% of the American adolescent population suffered from substance use disorders. This equates to 992,000 12 to 17-year-olds, or 1 in every 25. Of these adolescents, 741,000 suffered from illicit drug use disorders, and an estimated 443,000 suffered from alcohol use disorders. About 1 out of every 7 young adults aged 18 to 25 battled the substance use disorder in 2017. This age group has the highest percentage dealing with substance use disorders at an estimated 14.8%. The most common substance use disorders in this population were alcohol use disorders. 10% of individuals in this age range have alcohol use disorders, which equals over 3.4 million young adults. The second most common were cannabis use disorders, and substance use disorders involving prescription psychiatric medications were third. Among Americans aged 26 and up, over 13.6 million struggled with substance use disorders in 2017. This is about 6.4% of that age group. In this age group, substance use disorders were more common in men than women, with an estimated 8.7% of men suffering from substance use disorders, compared to an estimated 4.2% of women. It is estimated that over 1 million Americans aged 65 and up suffered from substance use disorders in 2017, which equates to about 2.1% of this age group. 978,000 of these older adults had alcohol use disorders, and 93,000 had illicit drug use disorders. Addiction affects people from all walks of life, but it is a treatable disease. Recovery is attainable. If you or a loved one is suffering from addiction, seek help.
I also want to apologize. I'm getting over a summer cold, so I will be coughing throughout the presentation. I'm also trying to drink liquids, as you saw earlier, to stay hydrated and keep the cough down. So I did a really quick statistics recap. One of the really most important ones that struck me was that 19.7 million people in America suffer from substance use disorders. At least that's the estimate as of 2017, based upon that video. However, only 1.4 were in treatment. Oh, and that's quite a staggering statistic. I think this kind of reminds us that we need to have this frank conversation, and we could do better. We can do better reducing the stigma surrounding mental health treatments and therapy, and we can do better increasing availability for certain populations. And that's something that we as a society have to change, but as clinicians and as future therapists, we play a major role in that. So remembering to advocate for our patients and their needs, but also remembering to reduce that stigma is so important, especially when you're talking about substance abuse therapy. There's a huge stigma attached to it. If you walk down the street and you ask any lay person what their perspective is on it, chances are they're going to have a negative association for substance abuse treatment. So working on educating the general population and reducing that stigma is so important, and I don't think it can really be understated. According to this video and according to my other research as well, substance abuse is higher in men than in women, about 2 times higher, actually. So that's something to keep in mind as well, moving forward. So here's the diagnostic criteria for gambling disorders. As we move on, I include the diagnostic criteria for other disorders, substance use disorders, substance intoxication, substance withdrawal, and you'll see, as in most disorders, there's a time frame put on it, and depending upon the number of symptoms that the patient is manifesting, that will impact the severity or the diagnostic severity of the disorder. As far as the symptoms, I know I talked about this a little bit, but if you look at the symptoms and you run down the list, and it's right in front of all of you guys, so I have every confidence that you can read those. The first symptom is a need to gamble with increasing amounts of money in order to achieve desired level of excitement. And this kind of speaks to tolerance. When you're talking about substances, the more you use a substance, the more you will need to achieve your desired high. So your tolerance increases over time. And this first example in here says, it speaks to that. It says you need to gamble with more money in order to get the same desired level of excitement. And they're subbing an excitement for high, or the clinical term for high. And you can also look at the rest of these. A pattern of lying to cover up losses and dire financial straits. If you ask anybody who is or has been addicted to a substance, chances are they've engaged in lying or covering up their substance usage from those around them, because there's that shame associated with it. So if you run down this list, there's a lot of overlap with what you'd expect to see in a substance use disorder, as far as the symptomology. And I think that's why it was reclassified as an addiction, because it really became clear that no, this isn't a behavioral disorder. This is an addiction disorder. So that's one of the major changes that happened and shifts that happened with the DSM-5, is that reclassification of the gambling disorder from a behavioral disorder to an addiction disorder. So that's pretty important. I also included from the text an adaptation of the quick reference chart So this is the differences in the classifications of substances which are considered addictive. And what I was really interested in is the change from nicotine to tobacco from the DSM-4 TR to the DSM-5. I am also really happy that we included other or unknown substances. If you work in the substance abuse field, if you even don't work in the substance abuse field, you can see that there are constantly new substances being introduced. And the one that really pops into my mind is bath salts. If you had asked 20 years ago somebody what bath salts were, chances are a layperson, maybe even a substance abuse therapist, wouldn't know what they were. They really became prominent in the last, I'd say 5 to 10 years. I know that in Bangor, when I was in high school, we were having this conversation regarding bath salts, which were considered a legal drug at that point because there were no laws against them. And then they became more popular on the internet and laws started changing. So that's an example of an unknown substance. And people can get addicted to those substances. So it's really important to include that option, kind of cover all your bases before the DSM-6 comes out. So I'm really happy they did that. Diagnostic criteria for substance use disorders. Again, you'll kind of see that timeline. It needs to be manifested and must occur within the last 12-month period, something that you saw in the gambling disorders as well. And we see that depending upon the number of symptoms or criteria the patient meets, there's going to be a difference in the severity of the diagnosis. It's important to address each of the 10 substances individually. This is something I did at Acadia when I was doing substance abuse intakes and indeed any mental health intakes. It's really important to get a full snapshot of the substances patients use and to create almost a timeline of their substance use. So some people, and I touched on this a little bit earlier, it's one of the risk factors. Earlier onset of use, even if it's of a substance that we don't consider so serious socially, and I'm talking about marijuana. Alcohol is more socially acceptable to use than, say, cocaine or methamphetamines or bath salts. Tobacco is more socially acceptable. Those are some of the more readily accessible substances, which if a patient begins using them early on, and I'm talking early adolescence, just popping into mind, I've had patients say that they started using substances as early as the age of 6, which really was quite shocking to me. So early onset and early use can indicate a higher instance of substance abuse in the future. So really being mindful of that, and double checking and cataloging when substance use started for each of the different categories is very important. And then there are 4 key areas, and this is going to come up again. So there are 4 key areas to diagnose, and that is impaired control, social impairment, risky use, and pharmacological. So a substance use must constitute a maladaptive pattern of consumption leading to clinically significant impairment or distress as manifested by 2 or more of these areas occurring within a 12-month period. So while a patient may not manifest having social impairment, their social groups may not be affected, and that could be happening for a myriad of reasons. A lot of individuals, and I touch on this later, their social groups, it could be triggers or they could be encouraging use. So their social impairment may not be affected, but if they're having impaired control and they're engaging in risky use, that could be needle sharing, straw sharing, it would qualify as a maladaptive pattern in consumption. So all substance categories follow this format, regardless of whether you're diagnosing for alcohol use disorder or opiate use disorder, they're going to follow this format. And there's, depending on the substances, there's a difference in the withdrawal side effects. So being mindful of that. Alcohol withdrawal is going to look very different from opiate withdrawal. It's going to look different from stimulant withdrawal. So here's a diagnostic criteria example. And I took this straight from the DSM. So I actually have the PDF version in Kindle, and I just screenshotted it. if you guys have the hard copy, it's going to be on pages 520 to 521. And I selected hallucinogen-related disorders. So phenylcyclidine use disorder. And you go down the pattern of usage. And this is, if you go to the previous slide, 2 to 3 out of the criteria would be mild, 4 to 5 moderate, 6 plus severe, and that's in A. So phenylcyclidine is taken in larger amounts or over a longer period than was intended, and this could work with opiates. This could work with benzodiazepines. This could work with alcohol. I mean, you kind of sub in the substance at the beginning of one. So instead of phenylcyclidine, you could say alcohol or opiates. And this is pretty common across substance use disorders. This phrasing, the way that this is structured. There's a persistent desire or unsuccessful efforts to cut down or control use. This could mean that there are instances of relapse. So being mindful that you've looked at their previous treatment history. A great deal of time is spent in activities necessary to obtain the substance. I'm just going to say the substance because this works for most of the substances we talk about when we're talking about substance use disorders. Craving or strong desire or urge for the substance. So you kind of just run down this list, and depending on how many they have, that would speak to the severity of their substance use disorder. And then the really important one is the tolerance, which you see a marked increase of the substance to achieve intoxication for the desired effect. And I kind of touched on this already when talking about gambling use disorder. You need more of it in order to get that desired effect, that high. And the effects are less with the same amount. And then it kind of touches on remission and sustained remission. In a controlled environment, I think this would be talking to a detoxification site or an inpatient clinic, or maybe a halfway house. And then there are specifiers, which are really important. Substance-free jails, therapeutic communities, locked hospital units, etc. So substance-induced disorders. This category is subdivided into two. So it's substance intoxication and substance withdrawal. And I'm going to give you a couple examples on the next slide. And they'll differ between substances. The timeline for withdrawal is different for different substances. The timeline for intoxication is different. So marijuana intoxication versus alcohol intoxication, just two more socially acceptable substances, are completely different. And in general, substance intoxication is indicated by the recent ingestion of substances, which result in cognitive and behavioral responses. Tobacco doesn't cause intoxication. You'll just be jonesing for a cigarette. So intoxication impacts how you think and how you act. So if you ever have a patient come in for an intake or come into the clinic and they're intoxicated, you can tell based upon their physical body language, their changes in behavioral, their changes in how they act, how they think. They might be more sexually or physically aggressive or inappropriate. Their behaviors will change. So while each substance will result in different symptoms of intoxication, there are common themes. So recent exposure or ingestion of a substance is important. So maybe if somebody had a drink 3 days ago, they probably aren't intoxicated from alcohol, but they might be experiencing withdrawal. Maladaptive behavioral, physiological, or psychological responses to exposure of ingestion of the substance. The present symptoms are not accounted for by another medical condition or mental disorder. So you might witness a patient who has delayed motor reflexes. So rather than just jumping on, okay, they're using a substance again, perhaps exploring other mental conditions or medical conditions, they could explain it better than substance use disorders. And you need to be mindful of the fact that they need to have ingested the substance as well. So behavior or cognitive changes is not the only qualifying factor to prove that they have a substance use disorder. So substance intoxication comparisons. Alcohol intoxication. This is one that's fairly familiar because, as I touched on earlier, alcohol is more socially acceptable. So chances are you've been exposed and you've seen or you've borne witness to somebody who is intoxicated with alcohol. So these are fairly familiar symptoms. The first diagnostic criteria is the person has to have had alcohol. They have to have ingested alcohol. They can't be diagnosed with alcohol intoxication if they haven't ingested alcohol. Clinically significant problematic behavior or psychological impairment. So inappropriate sexual or aggressive behavior, mood lability, impaired judgment. They might think that, okay, it's fine to go drive even though I've had 15 shots. So that would be impaired judgment. You should not be driving with that much alcohol in your system. So the developed during or shortly after alcohol ingestion. And then one or more of the following symptoms developing during or shortly after alcohol use. So slurred speech, incoordination, unsteady gait, nystagmus, impairment in attention or memory, and stupor or coma. And again, D says it cannot be attributable to another medical condition or better explained by another mental disorder. Very important that we are mindful of the medical disorders and other mental disorders that the patient is diagnosed with. So I just really want to quickly compare and point out the difference between alcohol intoxication and cannabis intoxication. Besides C, which you see there are different symptoms which develop as a result of the ingestion of the substances, you can see different problematic behaviors. And this kind of speaks to the neurotransmitters which are affected by the substances, and the different parts of the brain which are affected by the substances. And I think it's important to touch on this before I go any further. Cannabis intoxications, cannabis usage. I reviewed this previously in my psychopharmacology class. Cannabis is not one of those substances which you can become physically dependent upon. You can, however, become psychologically dependent upon it. And I think, actually, I know the text which if you're curious, I'm speaking to psychopharmacology, and I will post the link to this, Ingersoll and Rack. And it spoke to the fact that, actually, I can say this off the top of my head, I remember this. When you are talking about cannabis usage, you need to talk about set and setting. And what I mean by that is you need to talk about the individual's mindset. So if an individual is using the substance to avoid confronting something painful, and I'm going to just use an example of a patient that I worked with. One of my patients lost 3 very close friends and family members in the course of 2 years and was unable to visit their graves, did not attend any of their funerals, just basically essentially eliminated those evidence of those individuals' relationships from that patient's life. Photographs were taken down. It was 2 cousins and a best friend. All died of opiate-related deaths. 2 overdoses, actually 3 overdoses. One of them died in a very violent manner. They passed out on a train track, and they were hit by a train while they were unconscious. And then the other best friend of this individual was in treatment, relapsed, and overdosed. And this again was in the course of 2 years. And this patient never touched opiates, never touched any harder drugs, so anything harder than alcohol, marijuana, nicotine, all of which were used regularly. But I began to question the cannabis usage, and again, I'm an intern, because the patient's mindset when using the substance and the setting in which they use the substance were problematic. So unresolved grief, post-traumatic stress disorder related to the family member's death and the precipitating events surrounding that, all were causes of concern for my supervisor and I. And to be candid, I'm not sure how the case ended up, how the diagnosis played out, because this was a patient that presented towards the end of my internship. But when I think of cannabis use disorder, this patient is the one that comes to the front of my mind, because the mindset he had when he was using the substance and the setting in which the substance was used. So antisocial, isolationary tendencies, use the substance only when recollections of the previous events and the pain and the unresolved grief were coming into play. So that is an instance where I think cannabis use disorder would be an appropriate diagnosis when a patient is using it in an unsafe or an incorrect or a maladaptive setting, and their mindset or their mental health stability comes into question, and the use is associated with that mental health instability, or with avoidance. So when I'm talking about cannabis use disorder, I'm not talking about the general population, because I know that most people who, well, historically cannabis use has been shown in an unfavorable light due to social situations and the stigmas attached to that and historical policies. So I thought that was really important to touch on before I move forward. When we're talking about cannabis use disorder, we're talking about individuals who are using it to cope or deal with and using it as a maladaptive coping strategy. So that's why I brought that case vignette up for you guys to think about, considering the set and the setting one is using substances in. And that doesn't just apply to cannabis. I mean, if you want to break it down to the patient who is using alcohol as a maladaptive coping skill, talking to them about what are you thinking, where are you psychologically, what is your headspace when you're using it, and how are you using it? Are you using it, are you getting one drink with your friends at the bar, or are you drinking over 3 beers for a woman, over 5 beers alone in isolation, by yourself, because that setting is problematic. So keeping set and setting in mind when you're talking about diagnosis, especially regarding cannabis, is so important. So substance withdrawal comparison, caffeine withdrawal versus opioid withdrawal. Caffeine withdrawal is, I'm guilty. I drink a lot of caffeine. And when I don't have my coffee, I do get the headache. I get marked fatigue and drowsiness, and I get slightly irritable because my headache hurts. So prolonged daily use of caffeine, if you have a lot of caffeine all day, and then you just stop or reduce your caffeine use, and then within 24 hours, you start getting a headache, marked fatigue or drowsiness, dysphoric mood, depressed mood or irritability, difficulty concentrating or flu-like symptoms, nausea, vomiting, muscle pain, stiffness. And they have to cause impairment. This is interesting. Yeah, it says this with opioid withdrawal as well. These symptoms have to cause significant distress or impairment in social, occupational, or other important areas of functioning. So again, I want to compare the caffeine withdrawal, which it says 24 hours by 3 or more of the following signs. Opioid use has been heavy and prolonged several weeks or longer. So the time periods are completely different. And I don't know if I can go back. I don't know if I touched on this. Oh, okay. Also, the intoxication. I'm going to circle back to this because I don't think I touched on this. 1 or more of the following symptoms developed during or shortly after alcohol use for alcohol versus 2 hours of cannabis use. So that is, again, being mindful of the substance being used and the timelines it takes for those substances to take effect. And then in turn, the timeline it takes to detox from those substances. And for opioid withdrawal, you'll notice, again, the symptoms of withdrawal are completely different from the symptoms of withdrawal for caffeine. And that is, again, speaking to the neurotransmitters which are affected, and how these substances impact your brain. I also want to touch on the fact that opioid withdrawal can occur when an antagonist is administered. So if you ever if you ever in a situation where you have to use Narcan, or or one of your patients has to administer Narcan, or the patient themselves has Narcan administered, their brain goes straight into withdrawal, because the neurotransmitters which Narcan puts out displace the opioid neurotransmitters on the receptors and take those over. So the patient or the individual will go straight into withdrawal, and they will start experiencing 3 or more of these withdrawal symptoms. And if any of you have a chance, I would strongly encourage you all to go to Narcan training. I know that I did, and I carry Narcan on me. And they talk a lot about how to position the body so that an individual, when they come out of their overdose, for lack of a better term, coma, there's generally a jerk reflex. So positioning a body safely. And these are common symptoms. You'll actually see a lot of overlap between the withdrawal, which you see in the hospital session or intake session, because this is cessation of opioid use. So this is the withdrawal you will see your patients if you are doing intakes on opioid withdrawal. These are the ones they'll be talking about. And again, it says at D, the signs and symptoms are not associated with another physiological or medical condition. So methods of diagnosis. And I'm going to go over this really quickly. Again, here are those 4 key areas to assess: impaired control, social impairment, risky use, pharmacological criteria. Sorry, again. So audit, alcohol use disorders identification test. This one is really used. It's used for physician billing. This is the one that you generally get when you're at your doctor's office, and they ask you about how much you drink, how often you drink. It's a scale, and it's very effective for recognizing harmful or dangerous drinking patterns. And I hypothesize that this is the scale that was used to diagnose those 19.7 million individuals with a substance use disorder. So those brief interventions, because again, in the doctor's office, they just don't, most doctor's offices do not have the therapeutic resources to just set up an individual counseling session. So that's why there's that disconnect of only 1.4 million people who are seeking treatment. So drug abuse screening test. Again, this is one of those brief assessments that's used in the physician doctor's office quite frequently. Assist. So alcohol, smoking, and substance involvement screening test. This is used to assess problems that can occur from alcohol use. And it can be used for other measurements. It's primarily used to recognize people with moderate and severe substances that may lead to risky behavior. And then there's CAGE, which is cut down, annoyed, guilt, eye opener. And this measure is used to briefly assess alcoholic dependence concerns, but it does focus on detecting risk or drug use in non-dependent individuals. Drug testing and substance screenings are frequently used in med replacement programs to reduce co-occurring substance abuse that could be fatal. So once a patient is admitted into a narcotics treatment program, they might have these brief interventions done. And I also kind of want to touch on the fact that anytime you do a full intake or assessment, you should be doing, you should be going through those 10 areas of substance usage. And a lot of it is based upon self-report. Well, actually, yeah, most of these assessments are based upon patient self-report. So it depends on the rapport you've built with the patient and their willingness to change, which I'm going to talk about in motivational interviewing. So we can only go based upon the evidence that patients present to us, unless we're doing drug and alcohol screens, in which case we have that scientific evidence to back up. And those are used very widely in med replacement programs. And I know that a couple med management services use urinalysis as well, just to ensure that the patients are taking their medications as prescribed, so their medication adherence is where it's supposed to be, and that if they are having a substance abuse issue, that their medications can be adjusted as necessary, because as we know, there are a lot of medications which have negative interactions with other substances, so being mindful of that as well. So recommended evidence-based modalities, as I said, motivational interviewing, it's one of my favorites. And I swear I had the textbook. Here we go. Pardon me, I'm actually going to show you the book I'm talking about. So if you do not have this book, it is a gold mine. So this is Miller and Rolnick's 3rd edition, Motivational Interviewing, Helping People Change. And this, if you are in the substance abuse field, is low-key going to be one of your Bibles. So it was developed by DeClementi. No. Yes, it was. Miller and Rolnick are amazing too, though. So I made a mistake in the slideshow. Miller and Rolnick are the ones who developed motivational interviewing. DeClementi, I believe, is group therapy counseling. My apologies. Although group therapy counseling is extremely important for substance abuse as well. So Miller and Rolnick identified 5 stages of change: pre-contemplation, contemplation, preparation, action, and maintenance. So what I was saying earlier about assessments and the importance of self-report, if your patients are in pre-contemplation, they may not be willing to talk about their substance usage. In fact, they may not self-report. They may choose not to report their substance usage. So if they're drinking 2 bottles of wine every night, they may just say they're having 2 glasses because they're not willing to make that change. If you do have a patient come in who is in this stage, chances are they have been mandated by a court, or they have been asked by a family member, or strongly encouraged by a family member to be part of therapy. So they're not really willing to recognize that there's a substance abuse problem. They're not at that stage yet. They don't want to change. They don't see an issue with their behaviors. So really exploring how their substance use impacts their life and weighing the benefits versus the costs of it is very important during this stage. Then during the contemplation stage of change, the patient is aware of their substance use. So they've seen, okay, yeah, there's some bad things happening because of the way that I'm using alcohol, the way I'm using opiates, the way I'm using benzodiazepines, my methamphetamine usage, my any other fill-in-the-blank substance usage. However, they're not yet prepared to engage in meaningful change. They're willing to discuss the pros and cons, though. So these 2 areas would be where you would be engaging in what I'm going to talk about in a minute. No, just kidding. It's 2 slides away. Harm reduction measures, making sure that, if they are using heroin, that they have clean needles. If they're not using by themselves, so that if they do accidentally overdose, they do not die. Harm reduction measures are so important in these stages. And then in preparation stage, the patient is willing to change in the near future, and they have goals for behavior, but they have not yet taken action. So this is generally, this is the time, this is the stage of change you generally have a lot of patients come into treatment. They've considered it. They have weighed the pros and cons in private or with an individual therapist, and now they need your help. So they're coming to a place where they'll be able to get a referral to a detox center, or they'll be able to get into that narcotics treatment program, where they can go inpatient, kind of clean out, dry off from stimulants, because there aren't super methamphetamine. There are a couple withdrawal side effects, but it's mostly removing yourself from a situation where you can use those substances. And that's I mean, I know that there's a matrix model, which is being used in the Midwest primarily, where it's, I think, 3 months of inpatient care to ensure that individuals change their behavioral patterns, which is mostly CBT. And I'm going off on a tangent right now. And then there's the action stage of change, and the goals are set, and the patient is working on changing their lifestyle experiences and social circles. And I really want to accent this: their social circles. This is one of the most difficult changes for somebody to make, especially if they come from a family or a background where substance usage is rampant. Changing and making that huge social change and drawing that boundary to say, you know, I love you, but I don't love the substance you're using, and I'm not willing to engage in this behavior anymore, and I'm making this change for myself, can be one of the greatest impediments to sobriety for patients. So being mindful of that and meeting your patient where they are and being empathetic is so important in this stage. And in the final stage, maintenance, the patient is working on continuing to carry through on their changes. The primary goal of this stage is to reduce instance of relapse. So cognitive behavioral therapy. Education is the hallmark of this technique. So learning coping skills and recognizing interconnected factors regarding problem areas and triggers. Patients learn self-regulation, problem-solving strategies, and coping skills. And if I'm honest, we use kind of at least in my experience, I know that we use a little bit of DBT as well. In my limited experience, and I'm willing to admit it's limited at this point, there's a hybrid of CBT and motivational interviewing used when we're talking about addiction counseling and addiction therapy. So kind of like we touched on in this stage, when you're in the preparation, the action stage, using your coping skills that you have, using your problem solving strategies, and using that self-regulation, which you've learned with CBT, are so important so you can achieve maintenance. And the basic premise or assumption of CBT is that despite evidence of biological or genetic components to human behavior, especially at a macro level, is largely learned. And this is that important part about these social structures. If you come from a social structure or a family, or if you come from a place where substance usage is normal, and that behavior has been modeled for you, it is going to be so difficult to change that without changing your social structure. So there's an emphasis placed upon patient strengths, so what they can do, empowering your patients rather than focusing on the pathology and the shortcomings. Trust me, they know what's wrong. They know what they're doing wrong. Reminding them what they're doing right is so important, building them up. So focus on adjusting and shifting detrimental and negative perceptions or thought patterns. Changing the way you think and the way you see yourself is so important. Sorry, I've been coughing too much. And each client's behavior is shaped by personal goals rather than by universal biological drives. So we can overcome our biological drives and we can achieve our goals. That is so important. So this requires changing the way that patients think and behave. So that's changing negative self-talk and thoughts, reframing and restructuring, and tempering personal expectations for yourself and your situation. And I'm guessing we're all fairly familiar with CBT. It's one of those giants in the theoretical orientation world that's used very widely because of the evidence-based modality of it. So I was really surprised that the text, I'm not even going to try to pronounce that name. There are too many consonants at the beginning of it. The Zagluski, I did try, the course text did not touch on the harm reduction model. So I know that it was omitted, and I said at the beginning of this presentation that I was going to kind of focus on what was covered by the course text, but I really do feel like harm reduction is an important point of discussion if you are talking about addiction counseling. And I know from my personal experience working in a clinical setting that this is used often in addition to motivational interviewing, as I touched on. The goals are pretty simple. It's to reduce the potential harm to your patients or the individual using the substance. Sometimes abstinence is an unrealistic goal, and providers work for patients to simply reduce their substance usage, or to use clean needles as opposed to hang on, sorry. Hang on, I'm gonna get a tissue, so let me figure out how to pause. All right, much better. So substance reduction can be a method of compromising while still educating the patient and not demanding complete abstinence. And I'm going to touch on Alcoholics Anonymous and Narcotics Anonymous, yes, AA and NA in a moment. But one of the major objections I have to AA and NA is that it demands complete abstinence, which at some points is unrealistic. And I really believe in meeting the patient where they are, which is what harm reduction does. Substance use has and will be part of our world. Historically, you can see substance use interwoven with humanity's existence. Accepting this reality leads to a focus on reducing drug-related harm rather than reducing drug use. And if you've followed safe injection sites throughout the past couple of years, or Portugal's changing laws regarding substances, you can see, and that bears witness to the effectiveness of harm reduction strategies. And while I think it's really important to acknowledge the cultural factors as well when considering using harm reduction methods, I am a huge advocate for using it at least during pre-contemplative and contemplative stages of change. And it's becoming increasingly popular and increasingly common. In Canada, safe injection sites are being used to reduce the dangers associated with sharing dirty needles and solitary substance use, which I've touched on those dangers already in this presentation. So the goal is to reduce diseases associated with sharing dirty needles and reducing individuals who overdose in isolation. Because realistically, if you overdose accidentally in isolation, there is nobody to call 911 for you. So having safe injection sites could really reduce the instances of that. And I will include a link to New York Times article, which I'm referencing, regarding Canada's safe injection sites with a posting of this video. I keep on actually hitting the wrong button. So I touched on this a little bit. It's a traditional, AA and NA are traditional self-help approaches, and it's a 12-step program. You can see on your right the 12 steps. It's a non-medical model. So there are not therapists who run the groups. It's group therapy. It's insular. It's anonymous. It's a support system. And it's mentorship centered. I think one of the really important, I struggled with adding this to this slideshow just because there are drawbacks of AA and NA. Whether it's, as you see, God is all over this. So people with who do not have a spiritual orientation and who are not part of an organized religion really struggle with AA and NA. So to a degree, it alienates some populations. There's also the complete abstinence expectation, although there is more wiggle room on that. In recent years, they've changed that. I think the real strength of AA and NA, and the reason that we continue to advocate for joining a group if you do have a religious orientation or a spiritual orientation, is that so many individuals, as I touched on, have to completely overhaul their social groups when they come to the action stage. And AA and NA really provide that social support, that sense of being, that sense of having a community rooting for you if you've had to alienate or take a step back or take some space from your family, from your social group, and you essentially feel as if you have no one except for your clinical providers caring for you and rooting for you and helping you in your recovery journey. So I think that is the greatest strength of AA and NA. And they're everywhere. Another drawback is the social stigma attached to it. Even though AA and NA are based upon the premise of anonymity, if you live in an insular or small community, and I live in Maine, so I know quite a bit about those. Um, people know where and when AA and NA meetings are happening. So if your car, and people know your car, is parked outside one of the meetings, they know you're attending it. So it's not really anonymous, which is too bad. But again, that's the nature of the beast when you live in a rural, insular community. Additional interventions include brief interventions, as touched on, the PCP, nurse office setting, 20 to 30 minutes. The goal is to educate the patients, and it's really a harm reduction. So it harkens back to the harm reduction model, reducing your usage to more reasonable levels. So rather than having 4 or 5 drinks as a woman a night, maybe cutting back to 2 or 3. Rather than having 6 or 7 drinks as a man, cutting it back to 4 or 5. And the reason that I, of course, state those differences is because the World Health Organization has outlined how much alcohol a woman versus a man should be consuming, and what constitutes binge drinking. And I can't remember the exact statistics, but it also says how many drinks you should have per week. So that might be something interesting for you to look at, and for you to know for your patients. And again, I have that written down on a piece of paper. I have it typed up, and it's on my bulletin board, so I can photocopy it, hand it out to patients while I'm doing patient education. But off the top of my head, I don't remember it. Interventions, detoxification and withdrawal. So important that if a patient is detoxing, they go to a medical facility, because there could be some serious medical complications. It's very, very important that there's medical supervision to reduce physical dangers. And depending on what sort of community you live in a rural setting where there's a lack of community resources, that detox, I know for me, we send our patients to the hospital. We do not have enough staff. We do not have enough nurses. We do not have enough doctors. We don't have enough facility space to have a detox facility at the mental health hospital that I've been working at. So the hospital takes care of it. We sign release papers, and then an ambulance brings the fully detox patient over, and they go inpatient, or they go straight into the narcotics treatment program. Although oftentimes they start in inpatient units, so they have that support and they can continue and figure out those med dosages. Medication is a treatment modality. So this is medication assisted treatment. Suboxone, methadone, treat opioid dependency. And this is the one that really comes to the forefront of your mind. Your brain has undergone structural and neurological changes, and the patient has become physically and chemically dependent on the substances. So the medication-assisted treatments reduces, it does not completely eliminate physical withdrawal symptoms over a long period of time. We're talking 2 to 3 years at least, while allowing the brain to recover. And your brain is so amazing. The neuroplasticity is breathtaking, the way it is able to recover, even from extended substance abuse, is really quite phenomenal. So risk factors. Sorry, I'm going to take another drink of water. Risk factors include exposure to traumatic events and diagnosis with post-traumatic stress disorder. Those have been linked to substance use disorders. However, it's always important to remember that just because it's been linked does not mean that it will always cause that. It's particularly true of adolescents, specifically women. But it's important to remember, alcohol use disorders remain higher in males than in females, about twice as high, actually. And there's a high rate of comorbidity with other mental health disorders. And as I touched on earlier, early age of first use is a significant predictor of subsequent transition from alcohol or drug use to dependence. So the earlier you start using any substances, alcohol, primarily, that is an indicator for substance dependence or misuse later in life. And the risk factors for alcohol use in adolescents and young adults vary according to ethnic groups. And this could be due to lack of education, lack of access to resources, social setting, low SES, All of that goes hand in hand with substance use disorders. And genetic social factors, as I touched on. If you see mom and dad after a long day of work going to the bar, dad going to the bar with his buddies having 5 or 6 beers, it's been a long day of work, I need to have a beer, I need to have those 4 fingers of scotch, you're going to learn to start associating um, uh, heavy substance usage with it's been stressful, I need this. So you're more likely, a child will observe and learn that when you're stressed, you have a stiff drink or a beer to alleviate that stress. So that's really important as well. And historically, LGBTQ plus populations have always been considered more at risk for substance use. And as the Green and Feinstein article touches on, this was due to methodological flaws, recruitment of participants from bars, and there was a lack of appropriate comparison groups. So if you're recruiting from bars, chances are you are catering to a certain demographic. You are researching on a certain demographic rather than the whole. So you only get a snapshot rather than like a big panorama picture. And ultimately, compilation of research suggests that LGBTQ plus individuals, particularly women, are at a greater risk of alcohol and drug use disorders, report alcohol-related problems, and report having been treated for drinking than their heterosexual female counterparts. And you also, when talking about LGBTQ plus populations, need to consider HIV and AIDS considerations. Substance abuse is often related to HIV and AIDS because of risky behaviors. So unsafe sex practices, sharing needles, sharing straws, multiple partners. So this speaks to ethical considerations regarding HIV disclosures to sexual partners and needle sharing partners. And this is something, again, I would strongly encourage you to do the research. 19 states require that persons who are aware they have HIV disclose their status to sexual partners, and 12 states require disclosure to needle sharing partners. Having acknowledged this, as therapists, we are often privy to this information. So that leaves us in an ethical bind and an ethical dilemma. If we know somebody is practicing unsafe sex practices with somebody they have not disclosed their status to, where does that leave us? And this is a conversation I've had with multiple supervisors, because there was an instance where a patient was not disclosing, and they were sexually active with other patients at our facility. So how does that fall with our oath of non-malfeasance? And this is a question for you. This is something maybe you could discuss below, or something we could discuss at some point during class. How does this work with our oath of non-malfeasance? And what are your state's laws regarding it? These are things that we should be aware of as therapists or as future practicing therapists. Minority groups such as Latinos who experience discrimination are at a higher risk of substance abuse or dependence. And this is across the board. Minority groups, regardless, end all, stop all, who experience discrimination are at a higher risk of substance abuse and dependence. This could be due to historically different cultural and ethnic groups have been stigmatized and associated with higher addiction rates. I know that I live near a Native American reserve, and you'd be interested. It's absolutely shocking, some of the statements that you overhear coming from individuals who have lacked access to education and who are still making statements regarding substance usage in relation to minority groups. So it's our job to educate our patients and be cognizant of these stereotypes and make sure that we are not allowing our unconscious bias to impact our treatment of patients. And also, we're called to provide psychoeducation and care to all of our patients. I also think it's really important to consider our OSHA. When I'm talking about ethical considerations, it's really important to talk about the fact that if somebody is using substances and they are in medication-assisted treatment, we are legally and ethically required to reduce their medication and phase them out of treatment, because if they are using, say, alcohol and they're in methadone treatment, they could die. The negative interactions between those medications. So being aware of what your patients are using, and that might mean using urinalysis, is very important. So that's the end of my presentation. I'm so sorry I was long-winded, and I apologize again for all the coughing and the sneezing. Regrettably, I've been trying to get over this cold and it just can't kick it. So I look forward to hearing your feedback. If you have any questions that are kind of tangential related to this presentation, feel free to email me, mhousen@antioch.edu, or you can just include it in the comments. I'll try to read everybody's feedback because I'm really curious and I'm excited to see how you guys observe the material. So thanks so much.